The stretched zonules of Marfan syndrome keep the vitreous behind. Surgery begins with a 600 micron deep LRI-like incision and the creation of a scleral pocket which is 3 mm by 3 mm extending away from the limbus. A dispersive viscoelastic like viscoat is used to tamponade vitreous and create space. A cohesive viscoelastic like Helon 5 or Helon GV is then added to enhance the space, allowing the rhexis to be developed. Once the rhexis is developed, it must be kept in mind to keep an anterior flange of capsule of about 2 to 3 mm in the area of maximal subluxation to allow for the insertion of a capsular tension ring and to support a segment which will be required later in surgery. The next step is to make sure that the rhexis is developed well beyond the point at which iris, in this case used to support capsule, hooks are used. Otherwise, there is a risk of tearing it out as these are engaged. Once these have withdrawn the nucleus to a more central position, the rest of the capsule comes into view and the capsulorhexis can be completed. If a small flap is left, this can then be tidied up to make a curvilinear rhexis. Gentle but multiple waves of hydrodissection are used to avoid dislodging nuclear material but ensuring an adequate hydrodissection. A capsular tension ring, in this case a Morscher type 14A, is inserted. Care being taken to ensure that the trailing edge is guided into the appropriate position to avoid it springing into the AC or into the sulcus. The lens is soft, so it can be handled by manual irrigation aspiration wholly, taking care. Every time the aspiration is withdrawn, viscoelastic is injected to avoid flopping of the bag capsule complex and shalling of the anterior chamber. Thereby, the entire lens matter is removed in a stable situation. An Ahmed Segment, a Morscher type 6E from Morscher GmbH Germany, is then inserted with a needle already having been passed through the central segment. The two CIF4 needles on tenoproline are then passed full thickness behind the iris in front of the capsule and the loop withdrawn through the scleral pocket. The second arm repeats the same procedure. Once the loops have been retrieved through the scleral pocket, the needles are cut outside the conjunctiva and the whole suture retrieved. The knot is tied, and as it is tied, it disappears into the scleral pocket, hopefully never to be seen again. Once this has been achieved, an intraocular lens can be injected, in this case a soft port lens from B&L,